So today we're going to start with the 3 C's, okay? And so that is confidentiality, capacity, and consent. These are the 3 C's. So the 3 C's can help to strengthen your answers in medical interviews when you are considering certain dilemmas. So it's good to start with the 4 pillars as a means to kind of give arguments for and against in a situation. But then it's worth then considering the 3 C's to add additional information.
Yeah.
Okay. Not also to forget the fact that there are different types of ethical models as well that you could draw upon as extra information, because like we were kind of looking last time at those different types of models as well. Okay. So we've got 4 pillars, different types of models, and we've got the 3 C's, and then we'll start looking at those scenarios related to the COVID-19 outbreak.
Oh, I see.
Okay.
Yeah. Okay.
So let's start with confidentiality. So what do you think confidentiality is?
It's the right to keep the patient's what is it called, identity, I would say.
Okay, identity
and anything that might relate to their identity a secret.
Yeah, so it's to do with personal information.
Personal information.
And it's keeping personal information a secret, okay?
Yeah, so they might talk about like their symptoms and everything, but they'll probably keep them as anonymous and make sure no personal information.
Yeah, so you don't associate it with a person.
Yeah,
so you can have a case study when you're talking about public health, like we just were a second ago with COVID-19, and you can talk about patient X, or you can talk about, I don't know if you remember in the news, there was discussions about super spreaders. So there was a person that had been to Singapore to some kind of conference, and then they returned back to the UK, and then they linked back like a large outbreak in the region in which that particular person lived. In and around that area, and so from there they could work out and work backwards who has got like a new variant, for example, and then they would work back who was the initial person or group of people by working out who's been in contact with who initially as to who like created a large kind of like outbreak in a certain area.
Yeah.
So there was that terminology called super spreaders. And so in the news there was this person, he was a super spreader, but we couldn't say his name due to confidentiality because it's personal information that needs to be kept secret.
Yeah.
Okay. So they described the person in terms of like their movements and where they lived and so on. And it was also there to try to give people that were living in that particular area a chance to be informed, to then help to prevent themselves and protect themselves against potential spreading, right?
100%, yeah, I think it works both ways.
But then there are times when it's possible to break confidentiality.
Yeah.
Okay. So, for example, when the law dictates it, it's possible in order to help to prevent a wider public health issue, for example, at times. If there's a permission being given as well. So if, for example, you tell your doctor in another situation that you don't mind your name or some of your personal information being shared and not kept a secret, okay? So there's permission, there's law, these things, and also if there's major risk to others, okay? So thinking about either major risk to the patient or to the wider public. Okay, so it ties in nicely that into the public health kind of ideas that we're just talking about. So that's confidentiality, keeping things confident. Okay, so that's basically a right that people have with their personal information and health information. The next one is capacity. So what do you think capacity is?
I'm not really sure capacity. I mean, I wouldn't know.
Okay. What about have you come across the word capacity before? Maybe maths, for example.
Yeah, I mean it's the amount it can withhold.
The
amount,
like a liquid in a container, the amount that it can hold, right?
It can hold, yeah.
So think about that, but in terms of information to do with your health. So if you're giving a decision as a doctor, it's your duty to kind of give as much information as possible, so a particular patient can then hold that information and then decide how they process it.
I see.
So it's basically, you got to make a judgment about whether or not this person can understand, retain that information, understand its implications on their health and the wider health of other people.
I see. So
it's like a mental capacity.
Okay, mental capacity.
Right?
That makes sense. Yeah.
So you've got capacity is to do with whether or not they can understand, and whether or not there's a situation where maybe a particular patient is impaired in their ability to make a reasoned judgment related to their health.
Yeah, and if they are, then they're not.
And if they're not, then permission and capacity has to be then passed on to somebody else in and around. We've talked before about people that are like children, for example, or for example, people who have dementia.
Definitely.
So they can't make an informed choice in order to give a consent as to what treatment they get.
Yeah, they do not have the capacity to.
Okay?
Yeah.
So a doctor has to make a judgment on whether or not the person can make an informed decision to give consent or not consent for a certain treatment.
Yeah. Would it also link to, let's say the person's unconscious?
Exactly. So if somebody's been drinking too much, for example, right, they're not really in the situation to be able to make an informed decision because they're not thinking clearly. Or if somebody's in a coma, for example,
that's
as
what
well.
I was thinking, coma, so that would also have capacity.
So that's when next of kin comes into play, and written forms and so on, and next of kin consent and so on. Like if you're on the life support machine, for example, as well, right?
That also comes to next of kin consent.
So consent is important, Keith. That's the third C, consent.
Yeah.
So consent, what do you know by the meaning behind consent?
Consent, it's basically giving permission to something. So what is it called? Again, it could link back to confidentiality, where you give a consent to break your confidentiality, or you give consent to do maybe
some treatment.
Some treatment. So between choosing an option,
like a blood test or something, right?
You consent to do the blood test. If you do not, then you're not allowed to. So you gotta make sure you respect consent.
Or an operation, or
operation, all those.
But it also needs to be practical as well. Could you imagine every time a doctor? I mean, post COVID, I feel like we're always filling out forms, right, to give our consent to this, or we understand the risk of this and that. In a healthcare provision situation where there isn't necessarily enough time and resources to be able to then be walking around and getting people to fill out forms, there needs to be a level of practicality behind it as well.
100%.
Okay, so time needs to be kind of considered there too. So there are these different types of consent. You have that written and signed one for something serious, maybe like an operation.
Oh yeah.
Okay, so then they've got physical record. Or, for example, you can have... Go on.
Maybe what is called by them accepting it, so verbally agreeing.
There's a verbal agreement.
There's verbal agreement.
So, do you agree for me to, take your blood, take a blood sample, for example?
Yeah.
But sometimes you don't even need to... so that's, verbal consent by simply asking them. So that's the second one.
Yeah.
So you've got, written, you fill out a form or something, or sign something. You've got... the verbal consent by asking them something, but then you've also got implied. So if you get a vaccination, for example, and you sit down and it's very clear that you've lined up and made a decision to go, if you remember the COVID-19 vaccinations, I would physically go myself to the appointment, wait there, line up, go in the line, and then sit down directly in front of the person that's going to give me the vaccination. The implied bit is this. It's obvious that I understand what I'm doing. Okay, they'll ask some questions, just general questions, and in discussion to see if I am in my right mind and I have the capacity to make the decision. But then sometimes they may not need to go as far as, do you give me permission to give you my arm, so then to give your arm so I can inject you now with this as AstraZeneca vaccination. I mean, that's just, it's not that necessary. If, for example, I just put my arm out, that's an implied. demonstrating that I give consent for the vaccination.
Oh, I see.
So I could just offer my arm out. That's an implied consent.
Okay.
Okay?
Yeah, that makes sense.
Yeah? So also with consent, we need to think about the fact that there are three things that are very necessary with consent to have, okay? It has to be voluntary, okay? Not forced, okay? So can you think of an example where somebody might be forced to give consent to something?
Well, I mean, if a treatment is required to be given and there's a certain limit of time, I would say, then they would have to be forced. And I mean,
But they're still not giving consent though, right?
if they're
If
not,
they're being forced, just being forced in the first place, right? So, like one example I have that springs to mind is abortion.
yeah,
What if, for example, the partner of the female that's having the abortion has basically pushed the situation to say you must have the abortion, but they don't actually consent to it voluntarily. They just feel like they're in a situation where they have to. This needs to be assessed. So, for example, if you or at least worked out by the person that's conducting the abortion. So part of it is there's this kind of like pre-interview where they might ask, have you come here on your own will? Do you understand? And then they check the capacity. Do you understand what's happening here? And that after this, it's an irreversible, situation. And do you give consent voluntarily to have this procedure made in front of you?
yeah,
So it's for example, that's one example where somebody may not feel like they are,
yeah,
voluntarily consenting. So a condition of having consent is it must be voluntary. Okay. Another condition is that it must the person must have capacity in order to make that decision. Okay. So by asking them questions and so on, you can see whether or not they understand the information. And the final one, informed. That's right, informed. They have to be informed. So that's part of that kind of, at the beginning, you talk about what's happening here today. Yeah. So informed, voluntary, and consent must be given, whether that's implied or written or verbally said. That consent.
The consent, yeah.
Okay, does that make sense?
Yeah, 3 ways to give it. Yeah.
So that's your 3 C's basically. Okay, so I am gonna move on. I'm not going to play the video because basically we've discussed all of those things. Okay.
Yeah.
Another thing that needs to be considered when dealing with ethics. I'm sorry, the video is going to cut it off on the right hand side. So for those that are watching the video, that says you've got like a 1 letter on the right that's which cuts it off. Dynamism. Okay. So this is something which many medical students and doctors often forget, and that's the concept that a situation or a scenario might be changing.
Yeah.
Okay. So, for example, the amount of resources that the public health system has in order to help the wider population may either get better in time or get worse in time. So, therefore, a reevaluation of the kind of ethical kind of decisions that are being made by the healthcare providers needs to be continually assessed.
I see.
So that means, if you remember PPE, right?
Yeah.
Personal protective equipment, there was a shortage of it. But then after time, the politicians worked hard in order to try to purchase more or produce more PPE. So therefore, over time, there was more PPE available. So that kind of changes the ethics of who gets the mask, who doesn't get the mask.
Yeah.
Initially, when there are a limited supply of masks or ventilators,
yeah, it's different.
Right? An assessment, a more kind of critical assessment needs to be made of who needs it the most. Whereas once there's an excess amount of PPE or ventilators or whatever we're looking at, then that doesn't become a limitation anymore.
Yeah.
Okay, so that's what we mean by it's forever changing, and the best, so the best interests or ideal decisions must be made at particular times, might change. So continual reassessment is needed.
I have a question. So would this be, let's say, the patient has some kind of symptom and it leads to another? Would that be an example of
Yeah,
dynamism?
sure.
Yeah.
Yeah, sure. So you might have heart palpitations that then lead into full stroke. And so
You can't
at the
do
first
same
instance,
treatments. Yeah.
the dealing with the heart palpitations or the signs of, like poor heart health to start with,
Yeah.
becomes more severe as the symptoms progress. Okay?
Yeah.
So therefore, the treatment needs to be considered in a different way.
I see. Yeah.
Okay?
That sounds good.
Okay, so one famous saying goes, it is better to do nothing sometimes than to do something that's going to be wrong.
Yeah.
Okay? Or not good for that patient. Okay?
Yeah, that makes sense as well.
So that's basically the main concepts that we need to be looking at. Okay? Try not to forget about this. Okay? It may be that decisions become easier to make when one returns to a problem or a situation later on, or more often, that the patient changes their mind as well. Their autonomy, their situation of autonomy and decision making may change as well.
Yeah.
So it's important to reassess that, especially since they become more kind of informed or understand more information, digest the information that's given to them, or when their disease process has progressed, as we were just talking about.
Yeah.
Okay, so those are important factors to remember.
That makes sense.
So here are ethical, the medical ethics to do with the COVID-19 pandemic. Okay, and this will take more than the rest of this session to get through, because there are quite a few things involved with this. But it does tie into dynamicism as well as us now being able to draw upon scenarios that get us to consider the 4 pillars, as well as things to do with the 3 C's as well. Okay?
Yeah.
So, medical ethics explore some of the ethical dilemmas raised by the COVID-19 pandemic. Remember, this was a snapshot of when we were just coming out of lockdowns or in and around lockdowns, okay? So it has changed since then, some of these issues. But it's worth considering this because COVID-19 questions regularly come up in medical interviews. Okay.
Oh, okay.
So, what would you say ethics is at this stage?
Ethics is, I would say it's like these ethics, like the word itself, or ethics in terms of like in medicine. Well, I mean, ethics basically justifies what's morally right and wrong, and it expands to all the fields, one of them being medicine. So ethics in medicine, essentially we deem what is morally right and wrong, and we have different models in order to make it a bit simpler to understand that gray area, because if it's black or if it's white, then we get it. However, ethics can get very complicated depending on what the situation is.
Yeah, it helps give a compass and some guidance into some very difficult decision making. Okay.
Definitely.
The moral principles that govern a person's behavior and or actions. Okay. So what are morals? So morals can be defined as the standards of behavior, principles of what is right and what is wrong. So many factors contribute to shaping an individual's morals, such as people's family, religion, age, culture. All of these can change over time. As people kind of like develop more education or understanding or experience of the world. But then there are also some underlying kind of factors that shape what people think is right and wrong as well, such as like your family's background and what you've been taught, or religious beliefs, or so on. Okay, and the culture in which you live in. Like something that happens in one culture may be absolutely acceptable and completely unacceptable in another culture, right?
Yeah.
Such as apparently in Argentina or Brazil, in somewhere in South America, showing the soles of your feet to somebody is really rude, apparently. Whereas like if you see backpackers in and around the world, they maybe kind of like sitting down, waiting for a train with their feet kind of like up, that people can see as they're walking towards them. Maybe they've taken off their flip-flops because they're hot, right? And that is just really unbelievably rude in South America in certain places, right? Whereas perfectly acceptable in other cultures. Yeah,
definitely.
So this helps us have a framework on how we would not just answer ethical scenarios to do with the COVID-19 pandemic, but also ethical scenarios in general. Okay?
Yeah.
So this is key. 1, 2, 3, 4 framework. Start by not rushing. Take a step. So when you're presented a scenario and asked to comment on it,
make sure you
which
read
happens
through it,
but you may just be asked direct in an interview
asked.
situation. Take a second to pause, think to yourself, take a minute for yourself, okay, before you start to speak and answer. That's the first thing.
Yeah.
Right? Then think about what are the arguments for. Consider the points supporting an argument, and then think about what are the points that go against a particular argument. You don't have to have one stance on a situation that's given to you. You just need to demonstrate that you balance the pros and the cons, the for and the against. Okay.
Would you have to eventually say if you're pro if you're against it or for the argument, or can you just leave it with a balanced conclusion?
Well, yeah, you need a balanced conclusion, basically. So you think for and against, and then you demonstrate the reasoning as to why you weigh it on one side more than the other, but with a caveat of something else, right?
Okay. Yeah.
So it ties in with, as we're saying, number 4, that balanced conclusion, right? Summarizing your arguments and coming to a balanced idea. And never answer without considering both sides of the argument, because that will just be thrown back at you and say, but what about this? Okay.
Yeah.
So with that, the classic example is non-maleficence against beneficence.
Yeah.
Right. So which one outweighs the other as a result, and you've just got to comment on that at the end. Okay.
Yeah.
So we know the 4 pillars: autonomy, beneficence, non-maleficence, and justice. Pretty much every single video we've kind of summarized these at some point. Okay. So we're not going to go into it too much, but for the sake of video, I'm going to give a couple of seconds for people to pause this if it's their first video that they're seeing, just to pause in order to read. But these are key. These are the 4 pillars of medical ethics: autonomy, the right to decide over your own body; beneficence. So it's always important to strive, not always possible to always do good to our patients. Non-maleficence, do no harm. Chance to pause. Moving on. Justice focuses on the principle of fairness and and being equal.
Equal, yeah.
Okay, equality. Okay, and not being discriminatory towards any particular group for a reason. So we're going to go through some of these scenarios. So there's 4 major scenarios that we're going to look through. Okay, the first one being the ventilator shortages. Okay, so when faced with critical shortages during a pandemic, how do we decide who gets the ventilators? Okay, so COVID-19 had caused a significant demand of ventilators, but even though at one point there was an increase in manufacturing of ventilators, there was still not enough for every person that needed one.
Yeah.
Okay, if you remember, there was the critical care units didn't have enough ventilators.
Yeah, I remember.
And so the production wasn't meeting the demand. Okay.
Yeah.
So how do we decide who would get a ventilator and who doesn't in that situation? That's a tough one, right?
That's a very tough one.
And there's no definitive answer. I'll lead you in a bit to coming up with kind of some processes or strategies or frameworks that you can use in an answer in a sec. But let's just consider the question. How do you know who'd get the ventilator?
I mean, going by the logic that the most vulnerable should get, or the most affected at that point, should get it.
But these are people that are already affected. They're in the critical care unit.
No, yeah, but some people are affected more than others. Like I wouldn't.
But they've
say,
been brought into the critical care unit, and
true.
they
They all
cannot
need
breathe independently on their
independently
own.
on their own. So then it would go to the next thing, which would be the quality life quality life.
Okay.
It's called, which essentially says how many more years of how many more years of quality life can you live?
Okay.
And there could maybe be, we could, what is called, decide it on that. However, I mean, yeah, no system.
What about justice, right?
Yeah.
Oh, there we have a dilemma. Because that's discriminatory, right?
So yeah, there is discriminatory.
And we're also doing harm by not giving something that's needed.
Yeah.
Let's have a look. There are certain arguments you can use, okay? But well done for remembering the idea of quality of life arguments, okay? So quality adjusted life years, or QALYs, have long been used to decide decisions regarding the fair allocation of resources. The idea is that the resources should be put to use for those who would gain the most QALYs from the intervention. And we'll go through like how to calculate this with a video in a sec, but you've got a formula down there. You've got QALY equals the length of life times the quality of life. But then we've got something quite subjective there, quality of life. Who is the person, or how do we measure that one person's quality of life is better than another? In some instances, it might be quite obvious.
Yeah.
In others, a lot more subjective, okay?
100%.
So therefore, those with the best chance of survival with a good quality of life would be prioritized for ventilators. In this argument, I'm not saying this is the way we should go about it, but it's an argument. The opposing side of this is that those who are considered to have the least good outcomes will be denied ventilators. So it's a similar thing, just reversed around. Yeah. Who's going to have the most to give later, or who is going to have the least good will not have, right, in effect. Okay? The NHS spends £20,000 per QALY gained. That's a lot of money in order to add a little bit of extra life time, or a lot of money to add a little bit better quality as well. But it's putting it in terms of monetary value, that little kind of snippet there, a little kind of NB notes well. Okay? So that's a lot that's money, that's resources. Okay?
Yeah, definitely.
So an example of a QALY in COVID. Okay? So we've got the number of cases, and we've got the time since the first case. Okay? And we've got the health care system's capacity. If you remember, you were always hearing the healthcare system, the NHS is at full capacity. The NHS has got this long until they get to full capacity. The NHS has passed capacity. And then there's all sorts of political fallout as a result of that. Yeah, because it's affecting people's lives, the length of their lives and the quality of their lives, because there weren't enough resources in order to meet the capacity or the demand in order to try to give the care that was required to those people at the time.
Yeah.
Does that make sense?
Yeah, that makes sense.
So many countries have implemented lockdowns, or they had implemented lockdowns to slow down the rate of progression, to try and flatten the curve. And you heard that all of the time as well. The idea of flattening the curve, which is stretching over a longer period of time, the same number of cases, but right, and so therefore we don't have a larger number of cases above the capacity in which cannot be treated or supported.
So essentially, the affected people's treatment is spread out more.
So the idea is behind preventative measures, as many preventative measures as possible. That means trying to prevent the number of people getting COVID-19. Yeah. Right. By doing so, it will mean the speed of which transmission is happening will not be as rapid. So therefore, potentially the number of cases over a period of time will be less. But we know there's going to be so many people getting the disease anyway. So that is just basically, we can't stop it, but we're trying to prevent the spread and the speed as a result of that. So therefore, spreading the same number of cases over a longer period of time to enable the healthcare system to deal with the number of cases below capacity, so it doesn't overstretch the capacity.
So they kind of did it to what is called to make sure the healthcare system capacity wasn't being breached.
Overstretched or breached, correct. Yeah.
Okay.
So that's what that diagram is showing us. With no protective measures, the one on the left, we've got a large number of cases that cannot be looked after because it's stretched the capacity of the NHS.
Yeah.
The blue one is the ideal of what they were trying to do, mitigating the damage rather than stopping because they couldn't, right?
Yeah.
So keep it as low as possible or close to capacity as possible over a period of time, so therefore more people can then be treated and therefore more QALYs saved, length of time of people's lives, quality of time of people's lives.
I see, yeah.
Okay? So implementing a lockdown has a significant negative impact on the economy though, which is the counter argument. So it was a case of, do we want to have the economy, like, are we going to save the economy at the expense of a large number of people's QALYs and people's lives, or vice versa? Okay, or the other way around, vice versa.
Or are we going to spend...
Or are we going to protect the economy and allow a certain number of people to be kind of go over this peak, the capacity, but just see that as damage that can't be avoided if we're going to protect the economy. Something had to give.
Yeah, and I mean, I would say the economy is the one to give in this case, and it's the better
initially
one.
Yes, when we're in the emergency situation.
In the emergency, yeah, definitely,
because the capacity was so low relative to the spread.
Yeah.
Whereas once a number of people that are critically impacted by the disease is the minute that the capacity of the healthcare system will more easily meet the demands of the people with with COVID-19 because the effects are reducing due to various reasons, such as like vaccinations and such as other things like this, and so therefore then the economy could then start to be ramped back up again. Does that make sense?
Yeah.
So you've got that balance that was in play there. But here's the ethical dilemma. At what point does the harm to the economy become greater than the physical harm from the lack of resources? That's something we investigate later on when we look at people with like heart conditions that are unable to, or people cancer patients unable to have their needs met by the system because the economy's hurt so much that there are certain things that can't be reinvested into the system, or the wait lists are too long, and although we may be mitigating the impacts of COVID, we're not mitigating the impacts of other underlying health conditions that were in existence at the time. So it's a really difficult balance, right? And there's no one answer fits all. So all of this kind of political fallback that you would see, really there's more to it than that. Obviously, when you get to learn more about why decisions are being made. So, we've got a little video on QALYs.
Attention! Anyone who cares about the fairness and quality of healthcare, some insurers or health systems are using clinical and cost-effectiveness analysis to determine patients' access to care. But did you know value assessments based on clinical and cost-effectiveness analysis can limit access to care for chronically ill patients and people with disabilities when used by insurers and government? Here's how it works. The most common metric used in value assessments is the Quality Adjusted Life Year, or QALY. The QALY rolls up average findings into one number that represents the value of the life of each patient with a specific condition. Let's look at Jessica, for example. A person in perfect health has a QALY equal to 1, while a person with multiple sclerosis, like Jessica, has a QALY equal to 0.52. Jessica lives with a chronic condition, but has a full and happy life, raising children, working hard, and building lasting relationships. However, when viewed as a number rather than as an individual under a value assessments, Jessica's life is valued less than someone with perfect health, which means less value is also placed on treating Jessica. Despite the widely acknowledged ethical problems related to using QALYs, this metric continues to underpin value assessments. When used to make healthcare decisions, QALY-based methods will ultimately deem Jessica and others with chronic illnesses or disabilities as worth less than others, and that's just not right. To stay informed and learn about the impact of QALYs, visit our website at valueourhealth.org.
Okay, right. Here's another metric.
This video will give you a better understanding of what DALY means. How do we measure the impacts of a health problem? We can measure incidence, prevalence, hospital admission rate, mortality rate. But for health planning, we need more accurate indicators that reflect the true impact of a health problem on the population. Indicators should be able to compare the impact of different health problems and specific health problems across health systems. When a health problem occurs, two outcomes are expected: either premature death or living with the consequences or disability. When people die prematurely, they lose some years of their life they were expected to live. These years are years of life lost due to premature death, YLL. When people live with the consequences of a health problem, they lose some of their healthy years of life they were expected to live. These years are years lived with disability, YLD. Years of life lost due to premature death can be calculated by subtracting age of death from the possible life expectancy for that age. Life expectancy is a number of years a person can expect to live at any given age. This is provided by WHO. For example, if a man died from rabies at the age of 30, and life expectancy for 30-year-old men was 71, he would lose 41 years of his life due to rabies. Years lived with disability is calculated by
Okay, so there's another argument. So that was the QALYs argument, right?
Yeah.
Here's another one. First come argument. Some people feel that it's impossible to try and decide whether or not one person's life is worth more than another person's life because of justice, right? So therefore, they believe the decision on whether or not somebody should be given a ventilator or not should be left to chance. If there is someone who needs a ventilator and a ventilator is available, then they should get it. That's simple. And if there are no more left, then that's unfortunate for them. So that's also not great. Okay? No right or wrong answer.
I feel like also with the QALYs, there's a loophole to it in the sense that the ones with very low QALYs might never get the ventilator. So there'll be people with higher QALYs coming every time, and just they will keep getting the
I see what you mean, yeah. Will they be able to manage the accessibility to get themselves in a position in order to get there on the first come, first?
You'd have, I think this argument would also have to come into place, I guess, to some degree. So we could say that after, I don't know, a certain amount of days, if they're still not given a ventilator and a certain amount of days has been reached, they'll be put into a higher priority, overriding the QALY system.
Okay.
But at the same time, the QALY is the main priority. So that's like for the
mixing a range of models, right? That's the way to do it. Okay.
Yeah, and what is called the QALY would be the main thing to go by. But when we can find like a certain amount of days, we can agree on a certain amount of days, and based on the like when that point is reached, we could what is it called? We could put those
switch to another model.
Yeah, put those participants in priority and switch to that model for that instance.
Okay. Well, it's well thought out. So you understand the first come, first serve. It's pretty straightforward, right?
Yeah, it's pretty straightforward.
You know, is it right to deny any one patient just because somebody else gets, might need one later? If you need one now, it's important to give that to somebody now, right? So, thinking about the pillars here, beneficence. In this scenario, there are limited resources, So the opportunity to do good for one person is a lost opportunity to do good for another person.
Mm-hmm.
Yeah? A lost opportunity to do good is not the same as actively doing harm, as in non-maleficence. I think that's important to kind of highlight.
Yeah.
Measures such as QALYs allow us to identify where we can potentially have the greatest positive impact. That's a pro for that. The issue with QALYs is who gets to define quality of life. It's too subjective.
Yeah.
Okay? And who's putting the weighting on certain numbers that then give a final QALY score. Individuals can have a very different attitudes to quality of life as well, especially when it is their own. All right?
Yeah, definitely.
So, does quality of life necessarily equate to the value of that life? Something important to be considered. Okay? So, that's just, pros and cons over certain models with the lens of beneficence.
Yeah.
Okay? So I think we'll stop there. What we'll do is next time we'll look at elective procedure cancellation. See you later. And then we'll start looking at some other scenarios like dying alone in hospital.
Okay.
As in, at one point, no family members were allowed to go and visit relatives.
Oh, yeah, I remember.
Yeah. And the return of retired staff as well. There's the issue of the fact that aren't they more likely to be able to not survive a batch of COVID when they may not have a vaccine already, for example. They're retired doctors, but yet we need their expertise in the field. So these are the considerations and scenarios to kind of look at. So we'll continue with that next week.
Yeah, that sounds very good.
Okay.
Great.
So good job.
Thank you.
And see you next time.
See you next time.